Good afternoon, everyone. I'm here to present you my 9 months progress of my PhD titled as Residual Symptoms Following Total Knee Arthroplasty. So currently, there are 60% of surgeons are using Esmarch Tourniquet during Total Knee Arthroplasty in order to achieve better visibility during the operation. However, the compromised blood vessels and nerves could cause complications such as pain, hypoxia, or DVT. In our systematic review and meta-analysis, we found that the application of tourniquet not only does not improve the effectiveness of the intervention, but it elevates the risk of deep vein thrombosis by 1.59 times. Therefore, surgeons shouldn't use tourniquet during total knee arthroplasty. However, we need to understand its effect on the implant survival, and guidelines should be updated with our very important findings advising against the routine use of tourniquet. I'm András Zoltán Posta. I'm working as a second-year resident in orthopedic clinic Semmelweis University, and I am the first student of first-year class of CTM Cardio and Sports Science. That's why I am here today. On the screen, you can see my lovely team, and I would like to thank them for all of their help. As a resident working in orthopedics, I have a clear vision to operate people with knee osteoarthritis the best possible way. And in order to do that, we would like to study the different techniques of the surgery. I have 2 ongoing projects. I started the first one in last year, September, and the second one just 3 months later. My first project is investigating the effect of Esmarch tourniquet during total knee arthroplasty surgery. So osteoarthritis is a degenerative disease which can cause pain and stiffness, and it can affect all the joint, but most common in the knee joint, and it's the leading cause of disability in adult population. There are a lot of people affected by this disease. Just in the US alone, there are 14 million cases with around 1 million surgeries yearly, and this is an ever-growing number. We have projected surgery numbers around 2 million by 2030 and around 3.4 million by 2040. So you may be wondering what Esmarch tourniquet, my title, was all about. Esmarch tourniquet is an inflatable device. You can put it on the thigh to prevent the blood flow of the operated area. One day I was operating another surgeon, not with my mentor, and I was surprised to see that he didn't use tourniquet. When I asked him about that, he said that he didn't used to do it. Well, that was weird, so after some research, I found out that this is the case worldwide. Around 60% of surgeons are using it, and 40% are not, without guidelines or evidence. I think it's really bad thing to use anything in healthcare in the 21st century without proven it's useful, or at least proven it's not harmful. So our aim is to assess the impact of Esmarch tourniquet on short and long-term outcomes. Our clinical question is that, does the use of Esmarch tourniquet during total knee arthroplasty change the short and long-term outcomes? We are comparing operating with tourniquet to without tourniquet, and we have a lot of outcomes, including bleeding, pain, surgery time, and thromboembolism. After proving its feasibility, we conducted our search in 3 databases, and we got around 6,000 hits. And with the help of my lovely selection Fernando, I can see you, we narrowed it down to 83. And then after this reference and citation chaser, we got 10 new eligible articles. I would like to show you some results, but firstly, I would like to explain the 3 main subgroups we have. So there is 3 main subgroups you can use tourniquet. The first one is full tourniquet, where you apply it before the incision and deflate it right after the suture. There is the half tourniquet, where you apply it before the incision and deflate after the cementation process has finished. And there is the third one, cementation tourniquet, where you apply it just before the cementation process and deflate it right after. So if you ask 10 orthopedic surgeons why do they use tourniquet, 6 of them will say that because it's easier to operate in a bloodless surgery field. So how can we measure easy? It's not that easy, but the most objective way is to measure surgery time. And as you can see here, we included 33 RCTs with around 4,000 patients. And in the end, we got there is only 4 minutes shorter surgery with tourniquet. This is not a huge number, and if you know the fact that applying the tourniquet is around 15 minutes, then you have a 10-minute loss of time. If you ask again the other surgeons, orthopedic surgeons, why do they use tourniquet, the other 4 will say that they have less blood loss with tourniquet. Well, at least this is half true. In the operation, so you can see on the right side, intraoperatively, you have less bleeding, around, an average around 100 milliliters. But after the surgery, you can see on the left side, there is the same amount more bleeding. So in total, as in calculated blood loss or in transfusion, we can see no difference. So there is no more blood loss with or without tourniquet. And then the most important figure of ours is deep vein thrombosis. It's really important because one deep vein thrombosis could kill a patient. Here we included 25 studies with around 3,000 patients. And as you can see, across all the subgroups, we have around 60% higher risk of DVT. So I think it shows us that we shouldn't use tourniquet. So as a conclusion, we don't have shortened operation time or decreased blood loss, but we have a higher chance of getting DVT. So altogether, we shouldn't use tourniquet. Here you can see my first project progress. As you can see, I finished with the risk of bias and the grade assessment, and we are currently at the manuscript writing phase. My second project is assessing the effect of preoperative biomarkers on postoperative outcomes in patients undergoing total knee replacement. So I spoke a lot about osteoarthritis and total knee arthroplasty, but what I didn't say is that the fact that 1 of every 4, or regarding to another 1 of every 5 patients has some residual pain. We noticed something at our clinic, that there are a group of patients who coming in with really high pain and really low objective symptoms. And after an easy surgery, they got higher likelihood of residual pain. And right now, we are operating because of the pain and the range of motion, but from the patient standpoint, the pain is the most important. If we cannot eradicate the pain, maybe we shouldn't operate these subgroup of patients, but treat them conservatively instead. So our aim is to assess the preoperative biomarkers to create a predictive score to estimate the likelihood of residual pain. We have the question to do the preoperative data predict the residual pain in 3 and 6 months. We have as factors the preoperative data and outcomes residual pain as 3 and 6 months. And our hypothesis is that high subjective symptoms combined with low objective symptoms could result in a higher likelihood of residual pain. As a summary, I have 2 ongoing projects. I would like to finish the first one in the following 3 months, and the second one a year later. I would like to finish my presentation with the words of Weiner von Braun. Research is what I'm doing when I don't know what I'm doing. Thank you for your attention.
Thank you very much, András. Any questions?
Thank you. Great talk. So did you change your practice at the orthopedics clinic already?
Well, actually, I'm a resident in orthopedic clinic, so I'm not really operating that often. And
did the practice of the department change then?
Not yet. I want to finish my article, and then I would like to give a speech to the clinic, and then maybe they will change. I don't know. My supervisor, I said it to my supervisor, and he said that he tried to operate without tourniquet once, 20 years before that. He did 4 patients, and he noticed a bigger blood loss. I don't know. And he said that he don't want to try it again. He's my supervisor. So
and what
I don't know.
And the numbers are the 60% using, 40% not. It's a global number, so
yes.
It's not Hungary.
Yes.
It's not Hungarian.
It's global, but in Hungary it's around the same.
Okay. Very interesting.
András, can you clarify something for me? You had 33 randomized controlled trials in one of the forest plots. Did you only analyze randomized control trials?
Yes.
And these randomized control, you had plenty more.
Yes,
more
I had
than
around
33.
93.
So you had 93 randomized control trials, and
Yes.
these trials were designed to test the effect of the Esmarch tourniquet.
Yes. Yes.
Then how is it that there is still, in your background, it says there is not enough evidence, there is nothing that is suggesting to whether the beneficial
Yes.
or harmful. So,
Yes.
I mean, 90 RCTs is a lot.
Yes, there are a lot of RCTs with a lot of different results. So I was really like, I don't know how to say it. So when I started this project and I started to read these articles, I was convinced that I will have no result, because one article says that it's better to operate with tourniquet, one article says it's not better, one article says it's no difference. So there are a lot of RCTs. It's a really debated question.
Because
right
the question that comes to my mind is actually the Caprini scores and perioperative risk for DVTs. So if you're having 90 different randomized controlled trials, these patients are possibly balanced with each other, maybe based on DVT scores or maybe not. I would really love to see the risk of bias and grade assessments for this project.
Okay,
Next
I will
time.
show it to you
Next time.
Next time.
Anyways, great talk, really professional. So did you see any variations in the antithrombotic therapies?
Yes, so thank you for asking this question, because I had this question 3 months before that, and I partially answered wrong. So in 25 years of studies, there are a lot of different hospitals, a lot of different antithrombotic drugs to use, but I think it doesn't matter, because they always use the same in the control group as in the intervention group. So I think it doesn't matter.
I think DVT prophylaxis is a very important question, and different drugs have different drug mechanisms. So I think we don't know yet, but this should be examined if the type of antithrombotic prophylaxis has an effect.
Yes, but they always use the same drug in the control group and the intervention. So if there is a difference, that's not because of the drug, I think.
Until we have a look at it specifically, yeah, we can't clearly say.
I don't know.
But,
I'm just an ortho guy, so
yeah,
that's not my field.
yeah.
Is the cuff size and shape standardized, or it's different?
Sorry?
Is the cuff size, so the tourniquet size, pressure, size?
They can use different pressure, and they can use different sizes regarding to the patient size, of course.
And do you think it has no effect for the outcome?
I think, it's my opinion, I don't know, but I think higher the pressure is, the more likely they will have pain. But I think it not does anything with the DVTs, for example. And we found no difference in pain, really.
There was no study that checked this effect?
No. We can include, because I extracted the pressures as well, so we can do it as well. Okay.
Thank you very much, András.